Hello everyone. Today's video will be on 20 PYQs from the topic of endocrinology. So the first question here, a child with decreased levels of LH, FSH and testosterone presents with delayed puberty. Which of the following is the most likely diagnosis? And your options are Klinefelter syndrome, Kallmann syndrome, androgen insensitivity syndrome and testicular infection. Now let's just first rule out the options. So testicular infection, no, this cannot be a cause of LH, FSH and testosterone being low. Okay, this cannot be a direct cause. Androgen insensitivity syndrome, usually this has increased levels of LH and they have normal or high normal levels of FSH, right? So again, androgen insensitivity syndrome is not the answer. Klinefelter syndrome usually has increased levels of LH and FSH, okay, as there is low testosterone, there is increased LH, FSH. And Kallmann syndrome, this is hypogonadotropic hypogonadism. That is, hypogonadotropic means low levels of LH, FSH, and hypogonadism means low levels of testosterone and delayed puberty. So the answer over here is Kallmann syndrome, hypogonadotropic hypogonadism, and that explains the decreased LH, FSH and testosterone. Not a feature of hypothyroidism. Your options are short metacarpals, delayed puberty, delayed bone age and altered upper and lower segment ratio. Now first of all, altered upper and lower segment ratio, this is a feature of hypothyroidism. Okay, altered upper and lower segment ratio, this is definitely a feature of hypothyroidism. Okay, delayed bone age, yes, this is a feature of hypothyroidism. Delayed puberty, again this is a feature, although in juvenile hypothyroidism precocious puberty can also occur. Short metacarpals, this is not a feature of hypothyroidism. Short metacarpals is a feature of pseudo hypoparathyroidism. Okay, type 1A. This is a feature. Fourth and fifth metacarpals are short in pseudo hypoparathyroidism type 1A, and this is not a feature of hypothyroidism. Delayed puberty, delayed bone age and altered upper and lower segment ratio, these are all features of hypothyroidism. 8-year-old child presents with lethargy, multiple epiphyseal breaks, Wormian bones with growth retardation and mental retardation. Diagnosis is, now mental retardation. First of all, look at the clues in the question. Mental retardation is one of the clues. Then there is lethargy, multiple epiphyseal breaks and growth retardation, right? Now mental retardation, here scurvy and hypoparathyroidism, rickets is out, okay, but hypothyroidism leads to mental retardation, lethargy and growth retardation, right? So here the answer is hypothyroidism. Which of the following is false about 21 alpha hydroxylase deficiency? First option is most common cause of CAH. Yes, this is correct. Affected females present with ambiguous genitalia. Yes, because this enzyme deficiency causes virilization of females. So they present with ambiguous genitalia. Affected males present with precocious puberty. Yes, because of over virilization. And hypokalemic alkalosis is seen. No. 21 alpha hydroxylase, this has a low sodium and more potassium. So hypokalemic alkalosis is seen. This is the wrong answer. This is the false statement. The others are all true. Gonads to testis differentiation requires the SRY gene. Remember this, gonads to testis differentiation requires SRY gene. Precocious puberty, multiple cystic bone lesions and endocrinopathies, this is seen in McCune-Albright syndrome. Remember that in this syndrome, McCune-Albright syndrome, there is fibrous replacement of the bone by fibrous tissue and endocrinopathies and precocious puberty. So this thing you will see in McCune-Albright syndrome. Features of hypothyroidism in infancy include the premature closure of posterior fontanelle. No, there is delayed closure of fontanelles. Coarse facies, umbilical hernia, constipation. Yes, these are all features of hypothyroidism. Premature closure of fontanelle. No, this is not a feature. This is an all except answer. Okay. So features of hypothyroidism include coarse facies, umbilical hernia, constipation, but not premature closure of posterior fontanelle. Which one of the following is the earliest manifestation of Cushing syndrome? Loss of diurnal variation, increased ACTH, increased plasma cortisol, and increased urinary metabolites of cortisol. Now here they have specifically asked what is the earliest manifestation. Earliest manifestation of Cushing syndrome is loss of the circadian rhythm, okay, of the cortisol secretion. So loss of diurnal variation of the cortisol secretion is the earliest manifestation of Cushing syndrome. The other options, increased ACTH, there may be increased or decreased ACTH depending on where the extra steroid is coming from. Increased plasma cortisol is there, there is increased urinary metabolites of cortisol, but the earliest manifestation is loss of diurnal variation or loss of circadian rhythm. A 9-year-old boy presents with growth retardation and propensity to hypoglycemia. On exam, short stature, micropenis, increased fat and high pitch voice. The bone age is 5 years. Which of the following is the most appropriate diagnosis? Now here remember that this is a 9-year-old boy, there is growth retardation and hypoglycemia. There is high pitch voice. Now high pitch voice is against thyroid deficiency because here you will see hoarse voice. Alright. Again, hypoglycemia in adrenal tumor. No, there may be hyperglycemia as we commonly expect. Malabsorption alone has got nothing to do with micropenis and short stature directly. Okay, so again this option is out. And growth hormone deficiency, yes, short stature is in favor of growth hormone deficiency. Micropenis, bone age is 5 years although the child is 9-year-old, and growth retardation, tendency to have hypoglycemia, all this fits into growth hormone deficiency. Remember that even if you exclude the 3 options, you should have a very valid reason to mark the 4th one. If you don't find a valid reason to mark the 4th option, that means you are making a mistake. Read the question once again. A 10-month-old baby, previously normal, suddenly becomes distressed in his crib. The external appearance of genitalia was normal except hyperpigmentation. Blood glucose showed a level of 30 mg per deciliter. What is the most probable diagnosis? Now this question again, blood sugar is low, there is hypoglycemia. This can happen in 21 hydroxylase deficiency, it can happen in hyperinsulinism, it can happen in familial glucocorticoid deficiency, but usually not a feature of Cushing syndrome. So this is out based on the sugars. Now the genitalia is hyperpigmented, okay, except genitalia is normal but there is hyperpigmentation. Now in familial glucocorticoid deficiency, because of the elevated ACTH, there may be hyperpigmentation of certain parts of the body, and genital hyperpigmentation points towards familial glucocorticoid deficiency. It doesn't fit into the other 2 options, which is hyperinsulinism and 21 hydroxylase deficiency. So your answer here is familial glucocorticoid deficiency. Pendred syndrome is associated with, your options are hypothyroidism, increased cortisol secretion, hypogonadism, and increased ACTH secretion. Pendred syndrome, we all know that this is associated with hearing loss and a goiter or a thyroid swelling, and it can present with hypothyroidism. True about nephrogenic diabetes insipidus is decreased ADH secretion, receptor insensitivity in kidney, increased ADH, and commonly associated with Wim tumor. So here read it carefully. They are talking about nephrogenic diabetes insipidus. So these two options are out, decreased and increased ADH, because that is normal in nephrogenic DI. Receptor insensitivity in the kidney, yes, this is the cause, because there is receptor insensitivity in the distal tubule of the kidney in nephrogenic DI, and it is not associated commonly with WIM tumor. It is associated with Wolfram syndrome. Okay, so that's about nephrogenic diabetes insipidus. Short stature secondary to growth hormone deficiency is associated with normal body proportion, low birth weight, normal epiphyseal development, and height age equal to skeletal age. Now in growth hormone deficiency you do not have this. Height age is not equal to skeletal age. The normal epiphyseal development, no. Low birth weight, not always associated with this. Normal body proportion, yes. Short stature secondary to growth hormone deficiency has normal body proportions, short stature. A child presents with tetany. What is the first step? So the first step in treating tetany is treat with IV calcium gluconate infusion, and then you can start on the definitive management. The karyotype of a person with androgen insensitivity syndrome is, remember that these are karyotypically males, 46XY, and there is androgen insensitivity. So the karyotype is that of a male, 46XY. A 3-month-old male child presents to the emergency department with severe dehydration, hyperkalemia and hyponatremia. Genitalia is normal. Which test will be helpful? Now here again the options are renin, cortisol, aldosterone and 17-OHP. Here hyponatremia is there, so we will cross renin and aldosterone. Okay, 17-OHP is a screening test for congenital adrenal hyperplasia. 21-alpha hydroxylase is the most common, which presents with hyponatremia, hyperkalemia. It can present with adrenal insufficiency, severe dehydration and shock like picture clinically. So 17-OHP, when you are suspecting congenital adrenal hyperplasia, 17-OHP is the screening test you can send. So here the answer is 17-OHP. Cortisol, again there is no particular clue in this picture that this 3-month-old child should have elevated or reduced levels of cortisol. Your screening test should be 17-OHP to rule out a CAH first, salt losing CAH. Features of hypothyroidism beyond infancy are all except. So features are coarse facies, umbilical hernia, constipation, yes. But premature closure of the posterior fontanelle, no. This is not a feature. Delayed closure of posterior fontanelle is a feature. Treatment of childhood thyrotoxicosis. Options are surgery, carbimazole, propylthiouracil and radioiodine. Now surgery and radioiodine, no. The treatment of choice is carbimazole, methimazole or carbimazole. Propylthiouracil has a very high risk of severe liver side effects and acute liver failure. So propylthiouracil is not used in children. The ideal treatment will be carbimazole. A 6-month-old infant is brought with history of constipation, developmental delay. On examination, the infant is dull, has facial puffiness, large tongue and umbilical hernia. The investigation most important to lead towards diagnosis is. Now look at the options very carefully. Karyotyping, rectal mucosa biopsy, hemoglobin and T4 TSH assay. Now hemoglobin has nothing to do directly with the developmental delay or umbilical hernia. So we will rule out hemoglobin here. Constipation, yes, Hirschsprung disease, it can point towards that, and rectal mucosal biopsy will be helpful. But again, Hirschsprung disease has got nothing to do with other things directly mentioned over here, developmental delay and umbilical hernia and facial puffiness. Karyotyping, now this is important because these features, constipation, developmental delay, the baby being dull and there is a large tongue or proportionately large tongue, umbilical hernia, this fits into Down syndrome. Okay, so karyotyping, yes, this is a possibility that can lead towards diagnosis. But then again, the last option is T4 TSH assay. All these features, that is constipation and dull faces, facial puffiness particularly, okay, and large tongue and umbilical hernia, all these also point towards hypothyroidism, which is a treatable condition. So if you have to choose between karyotyping and thyroid assay, choose the thyroid investigations, because hypothyroidism is the single most preventable cause of mental retardation and also developmental delay. So T4 TSH assay is the most appropriate answer in this setting. And the last question is, all of the following can cause precocious puberty except 17 alpha hydroxylase deficiency, 11 beta hydroxylase deficiency, 21 alpha hydroxylase deficiency, and none of the above. Now look at this picture very carefully. Here 17 alpha hydroxylase. So when you don't have this enzyme, these products, pregnenolone and progesterone, these do not go ahead into the cycle and become androstenedione and testosterone. Okay, so androgens do not develop when you don't have this 17 alpha hydroxylase. So 17 alpha hydroxylase does not present with precocious puberty. In fact, it can present with delayed puberty or sexual infantilism. 11 beta hydroxylase and 21 hydroxylase deficiency, as you can see here, 21 hydroxylase deficiency, when it is there, all this gets converted and goes into this cycle where it is forming testosterone, right? 21 alpha hydroxylase and even 11 beta hydroxylase. So in these deficient enzymes, this is what is formed and virilization of the genitalia happens, and that can present with precocious puberty. So the answer here is 17 alpha hydroxylase deficiency does not present with precocious puberty, and it rather presents with delayed puberty or sexual infantilism. So those are the 20 questions for today, guys. Stay tuned for more videos.